Uh, Bismillahirrahmanirrahim. My name is Hakeem Zada. I'm a PhD scholar in Department of Microbiology, Cohort University of Science and Technology. Today, my topic of presentation is molecular prevalence of multi-drug-resistant Klebsiella pneumonia isolates in Khyber Pakhtunkhwa, Pakistan. My today presentation will include introduction, objectives, methodology, results, conclusion and recommendation, preferences and acknowledgements. So first of all, introduction. Klebsiella pneumonia is a gram-negative bacteria belonging to the group of Enterobacteriaceae, belonging to family of Enterobacteriaceae and is a major source of nosocomial infection. Presence of Klebsiella pneumonia in environment, contaminated instruments, and healthcare workers' hands have all been implicated in transmissions. Klebsiella pneumonia infects multiple systems of the body like urinary tract infection, digestive tract infection, respiratory tract infection, etc. For identification, multi-locus sequence typing has been widely used to characterize Klebsiella pneumonia. 7 genes are important in molecular characterization, including RPOB, GAPA, MDH, PGI, 4E, MB, and TON-B. And treatment complication is the recent emergence and is due to ESBLs and Klebsiella pneumoniae herpapindimases. Multi-drug resistance of Klebsiella pneumonia is recognized in healthcare setting as a cause of highly morbidity and mortality. Some MDR Klebsiella pneumonia become extensively drug resistant Klebsiella pneumonia that have few therapeutic options. Molecular analysis of virulence genes of clinical isolates are useful to study the mechanism of development of Klebsiella pneumonia-associated infections. Virulence-related genes encoding for LPS, adhesins, fambrii, and capsules are linked with infectious clinical forms and antibiotic resistance. Despite of the importance as a major pathogen in clinical setups, limited data is available regarding molecular epidemiology of MDR and virulent Klebsiella pneumonia of Khyber Pakhtunkhwa. The finding of the proposed work will be helpful in improving therapeutic management of Klebsiella pneumonia associated infections in hospitals. Objectives of my studies are to characterize Klebsiella pneumonia isolated from clinical samples, to investigate the phenotypic and genotypic profile of antibiotic drug resistance, to analyze the virulence factors associated with pathogenesis, to detect and analyze mutations in selected virulence and drug resistance genes. So, methodology. First of all, the study has been approved by Cost Ethical Committee. Sample collection, urine, blood, stool sample, and sputum, and other clinical samples were collected from different hospitals of Khyber Pakhtunkhwa, Pakistan. Methodology sample, first of all, the sample were collected from different hospitals of Khyber Pakhtunkhwa. All these samples were projected, around 488 samples were collected from different hospitals of Khyber Pakhtunkhwa. These samples were projected for culturing. Out of these, they were seen for positive or negative. Either these are positive or negative. If these are positive, then the positive samples were projected for confirmation of Klebsiella pneumoniae, like strength test were done, phenotypic characterization, and 16S RNA PCR confirmation were done. Drug susceptibility in the positive cases, drug susceptibility testing were done, in which non-MDR, MDR, and XDR were differentiated. After that, different PCR procedure were performed, like MLST procedure, multi-locus sequencing techniques, PCR for TON-B, NB, and GAPA, and PCR for BLA, TEM, and TX, and PCR for virulence genes were performed. After all the confirmation, after all these PCR, the nucleic acid were sent for gene sequencing, and mutation analysis were identified using bioinformatic tools. Different primers were used in my study, including BLA, CTX, M15, BLA, TEM, BLA, SHB, BLA, KPC, BLA, OXA, BLA, NDM, etc. Results. First of all, drug susceptibility testing, antimicrobial susceptibility testing. So in the antimicrobial susceptibility testing, Different antibiotics were used against the Klebsiella pneumonia isolated from various clinical samples. In non-MDR Klebsiella pneumonia, the most susceptible antibiotic was amikacin, which is 96.8%, followed by meronim, which is 95.8%, and imipenem, which is 92.6%. While the most resistant bacteria, the most resistant antibiotic was augmentin, amoxicillin plus flavulonic acid, which is 82%, ampicillin, which is 79%, and followed by cefran, which is 70.5%. In MDR strains, the most resistant antibiotic was ampicillin, which is 100% resistant, followed by augmentin, which is 99% resistant, and ceftriaxone, which is sulfamethoxazole plus trimethoprim, which is 93.1%. And the most susceptible antibiotic in MDR strains are again amikacin, which is 80.2%, and imipenem, which is 68.1%, followed by meropenem, which is 68.2%. Distribution of isolates of Klebsiella pneumonia among clinical samples. So in the positive isolates, urine samples were 116 samples, in which 63 were non-MDR, 49 were MDR, and 4 were XDR. While in blood samples, 100 sample of blood, 72 were non-MDR, 41 are MDR, and XDR were only 3. Out of 16 sputum sample, 12 were non-MDR and 3 were MDR. Only 1 was XDR. And out of 29 pus isolates, 14 were non-MDR and 13 were MDR, while no XDR sample were detected in the pus specimens. Sample collection frequency of samples among different hospitals. So we were targeted number of hospitals of KPK, including Hyderabad Medical Complex, KTH, LRH, DHQ Mardan, DHQ Swat, and DHQ Cohort. 100 sample from each HMC, KTH, LRH, and DHQ Mardan were collected. 50 were collected from DHQ Swat, and DHQ cohort were collected 38 samples, in which the shown frequencies was found in urine positivity, blood positivity, pus positivity, and sputum positivity. Frequency of ESBL and carbapenemase in different clinical samples. Out of 116 total isolates from urine, 32.2% in non-MDR ESBL producer, while non-MDR carbapenemase producer was 33.3%. While MDR ESBL's producer were 38.2%, and carbapenemase MDR producers were 29.6%. In blood, 110 sample isolates were collected, in which 29% were non-MDR ESBL's producer and 37.5% were non-MDR carbapenemase producers, while 32% MDR ESBL producer and 21.8% were MDR carbapenemase producers. Out of 16 pus samples, 19.3% were ESBL producers in non-MDR strains, while 16.6% carbapenemase producers in non-MDR strains. And in 19.7% were ESBL's producer in MDR strain, and 37.5% were found in MDR strains. Out of 29 total positive sputum cases, 6.5 ESBL producer were found in non-MDR strain, 12.5 for carbapenemase producer in non-MDR strain, and 9.8% ESBL producers were found in MDR strain, while 10.9% were carbapenemase producer in MDR strains. Different genes, ESBL genes were identified using PCR techniques. So BLA, SHV, BLASTM, BLA, CTXM14, BLA, CTXM15, and BLA OXA were detected in the recent studies. This is the PCR analysis pictures of the study done in university. PCR analysis of ASBL and carbaphinimase gene in clinical isolate is shown in the picture, which is obtained from the machinery. Conclusions and recommendations. This study concludes that there is high prevalence of MDR, Klebsiella pneumonia is becoming a severe problem in major hospitals of Khyber Pakhtunkhwa in the north of Pakistan, as many strains are developing resistant to most available antimicrobial agents. Therefore, it is important to emphasize the clinicians for choosing an appropriate antimicrobial regimen based on proper culture and sensitivity results. New patterns of antibiotics should be designed that could play an important role in the future. And these all are references, which is the data is obtained from all these references and acknowledgements. I am really thankful to Department of Microbiology, Kohat University of Science and Technology, Mubarak Diagnostic Laboratory and Research Center, Peshawar, the Department of Health, KPK, Clinical and Lab Staff, Lead Reading Hospital, Hyderabad Medical Complex, Faber Teaching Hospital, CMH Peshawar, etc. All participants for clinical samples. Thank you so much for listening me.